Senator Bradley will be a little bit late this morning, but we will start without him. And we will open the hearing on House Bill 322 and welcome the prime sponsor, Representative.
Good morning, Madam Chair, from the great town of Hampstead and senators. You may remember a major publicity about a surgeon at Catholic Medical Center and the 20 malpractice claims against him. The Boston Globe investigative team did a several-part series about this, and there were a few pieces in the Union Leader as well. I was asked to be involved in this from the get-go and was quoted extensively in both papers. There were two parts to this series of events. Number one involved internal matters at CMC, and I was only peripherally involved in this. But the other is, why were 20 malpractice claims made publicly known on the website of the Massachusetts Board of Medicine, but none on the New Hampshire Board of Medicine website? I pursued this issue. My conclusion was there was no laziness or bad action on the part of New Hampshire Board of Medicine. They were following different protocols. The question is then, what should the protocols be? Because on the one hand, I was getting phone calls. Why are we learning about this from a Boston newspaper on a Massachusetts website when the alleged events are taking place here in Manchester? Well, we want to get the balance. We want to make information known when it should be, but on the other hand, we don't want to overdo it. You know, when somebody's accused of something, it's front page banner headline at the top of the paper. When they've been proven innocent, it's page 26 under the fold. My wife is a family practice physician. Believe me, I know that there is a sweet spot in the middle here somewhere between lack of disclosure and overdoing it. So the bill was very simply to convene a group of stakeholders, and some of them are behind me, that would look at this issue to find that sweet spot. How much should be made known to the public? And when should we still, barring anything further, keep quiet for now? I have an amendment, which is kind of funny when you think about it, because somewhere along the line, the 4 people that the House of Representatives were to appoint to this, 2 came from ED&A, 2 came from Health and Human Services. Great committees, great people. I don't serve on either one of them anymore. So this amendment will add a 5th person, and in consultation with the Speaker's office, we have a good guess who that 5th person could be. So that is my bill, and this is my amendment request, if I may, Senator. Oh, I'm sorry. Cam.
He keeps us organized.
Okay, good. I have one of those too. Thank you. And that's my story. They will provide great support and answer any technical questions, but I'm happy to answer any questions you may have of me.
Any questions from the Senator?
Thank you, Madam Chair. Good to see you, Representative. So I'm just looking at membership. You know, we're very stretched thin in the Senate. So you have 3 members of the Senate. I'm wondering why you have so
Does it say 3 or 2?
Oh, on the amendment. Okay. So you've reduced the number of senators.
Yeah, I did the math of, 24 versus 400. You're welcome.
Thank you.
Yeah.
Any other questions? Would you be agreeable to dropping it down to 1 senator?
I would.
Okay.
And most likely the one who is very interested in the subject and will be with us. I don't suspect we're going to have more than 1 or 2 meetings. I think we'll all do our homework ahead of time, see what other states do, talk amongst ourselves in ways that are completely 91A legal, and meet once or twice.
All right. Any other questions from the committee? Seeing none?
Thank you.
Representative. David Conway.
Good morning. Chairman, members of the committee, thank you for the opportunity to testify. My name is Dr. David Conway. I'm testifying as a public member. I have submitted testimony to you. I think I sent emails to all of you, and I distributed some copies today in case you hadn't had a chance to look at it. I don't plan on reading through it. I want to highlight a couple of things that I think are important. First of all, I'm a retired board-certified OBGYN. I worked in private practice for a number of years and then joined the faculty at the New Hampshire Dartmouth Family Medicine Residency at Concord Hospital for approximately 16 years. I think that both Dr. Perencevich and I can give a fair description of the function of the previously existing medical review subcommittee as well as the Board of Medicine. He's not able to appear today. I talked with him over the weekend. He's in Cincinnati with a severely ill brother, and he's just very sorry that he couldn't be here. And he sent some testimony that he edited over the weekend. I served on the medical review subcommittee for 6 years, was president for the last 2 years. I was on the Board of Medicine for approximately 6 or 7 years, was president of the board for the last 2 years. I have a fairly good understanding of a highly functioning process where complaints were addressed in a timely fashion and board decisions made in a timely fashion. Dr. Perencevich's testimony really describes a very accurate timeline since his tenure began, which was before mine. And over that timeline, the number of licensees increased, the number of complaints and investigations increased, and yet in 2015, when the Office of Professional Licensure and Certification was established, the administrative support decreased significantly over time, which hindered the board's ability to fulfill its mission to protect the patients of New Hampshire. The medical review subcommittee was eliminated this past July, as well as the position of physician investigator. And at the time, I was the physician investigator. A combination of the decreased administrative staff, as well as the pandemic, led to a significant backlog of cases. When I became investigator in 2022, there were cases going back to 2018 or 2019 that had not been seen by the existing investigator. I strongly urge passage of this bill. I think there has to be an examination of this process to make sure that it's functioning to fulfill the mission of the board. Right now, it's still called the Board of Medicine. It's more like the board of OPLC. That the goals of efficiency and cost savings are admirable, but they really have not panned out as far as helping the investigative process. Just to address Representative Pearson's comments about the lawsuit at CMC, when that came out, I was appalled. I said, how could we miss that? And did we ever see these cases? And I didn't think we had. In talking to Nick Perencevich, he was the person who investigated the cases because lawsuits were submitted to, or settlements were submitted to the board. And I'm sorry, I just lost my train of thought. And apparently in conversations with Dr. Perencevich, you prodded my memory, and those were determined to be they were not determined to be subject to discipline. The only thing that becomes public are decisions of the board that lead to discipline. No further action, unfounded letters of concern are all confidential, and they're not listed on the website. It's not open to the public. Right now, statute requires that disciplined physicians or licensees are public information. So I apologize for my poor memory, but it's from what Representative Pearson said, there was no problem with the process at the time. I would be open to any questions.
Thank you, Senator Birdsall, and Dr. Conway, thank you for coming this morning. I was looking at both your letter and the letter from Nick Prensevich, which I did see Nick's ahead of time. So my question is about the physician investigator. Is there, so if these cases are being investigated now, which is obviously be the subject of a conversation in this study committee, if they're being investigated now, is there a medical presence involved in these investigations?
I don't know. I've not been the investigator since July, the end of June 2023. And I don't know what the current process is.
Okay, so I'll save that question for, I imagine Ms. Courtney's going to come up and speak. Great. Thank you, because yeah, that both of you reference in the historical perspective, and it just leads me to believe, well, I want to clarify if there's a, like, who's actually investigating these cases and what's the medical perspective on that?
Just my personal perspective,
Yep.
that cases that either lawsuits, complaints from individuals, the statute requires that they meet criteria for discipline, for gross negligence, repeated negligence, so that cases where there are some nuances where it doesn't exactly meet statute really require the evaluation of a physician.
Okay.
And for instance, just in my own personal career, I was in private practice in rural northwestern Pennsylvania, and I was seeing a patient for the first time who was pregnant with her third or fourth child, who at the completion of her previous pregnancy had had her tubes tied by a general surgeon because her OB provider did not do tubal ligations. So when I saw her, she asked me if I would tie her tubes after she delivered. And I said, well, I would do it if I could do it laparoscopically, where I could,
Yeah.
and it would be a 6-week delay for her to recover from delivery, where I could put a scope in and I could really see what had the previous surgeon done. And she agreed to that. And when I did that, I saw that the tube on one side had been ligated very clearly. The tube on the other side was completely patent, and a structure called the round ligament, which is right next to it, which is a tubular structure that is very similar to it, had been very adequately ligated, which did nothing to keep her from getting pregnant.
Okay.
So if you look at consents for sterilization, part of it is that the procedure may fail. Well, if you don't do it right, it's going to fail. So I think a physician would really need to have some insight into that process before saying, oh, this is part of the complications of tying tubes. Well, okay, but did he do the right procedure? So there are nuances.
Quick follow-up if no one. So is it your position that in some of these more, say, nuanced cases, that either a physician that is a specialty provider in that medical area, or, would be consulted, either hired or consulted or whatever mechanism to bring them in to look at the case?
I think that a physician, whether they be a specialty person or not, needs to have the first evaluation, because they would be a little bit more sensitive to the possibility, oh, we need more information.
Okay. Thank you. All right. Thank you, Senator Birdsall.
Any questions? Any other questions from the committee? Seeing none? Thank you, Doctor.
Thank you very much.
Lindsay? Welcome.
Didn't have that far to go. Thank you, Madam Chair, members of the committee. Lindsay Courtney, Executive Director, OPLC. OPLC is not taking a position on this bill. I would say that there are a lot of questions that could potentially be resolved by a committee. I think I disagree with certain comments made by Dr. Conway, although we agree to disagree. We've had those conversations. But I think the question that he has raised, and maybe Representative Pearson, is really, what should the procedures be? And we certainly wouldn't oppose hashing that out with a subcommittee. I did want to answer your question, Senator Prentice, which is that, yes, there is a physician involved. We do have a contract with the physician right now. And we did release an RFA to hire additional consultants for physicians to assist with the investigative work. So that is part of the process. Not all complaints require review by a physician. I think some complaints are clear on its face that they could be dismissed, and so those are routed to the Board of Medicine for consideration sooner, which is part of the changes that happened last legislative session. But certainly, we wouldn't oppose examining the issues. I think the one thing that I would note is that as Dr. Conway and I agree, is that the operations are really governed by the office at the moment and apply across the board to pretty much every board in accordance with our administrative rules, which are the PLC 200s. So I think an examination, certainly there could be an examination into the Board of Medicine specifically, but I think that finding, any findings and recommendations would have to be extracted to apply across the board. For example, if there's a decision that information should be made publicly available prior to adjudication, we would anticipate that would apply agency-wide and not specifically to Board of Medicine findings. But beyond that, I don't have any comments, and I'd be happy to answer any questions.
Thank you, Director Courtney. Good to see you. And
Likewise.
Thank you for taking your question number one. Good. So, and I understand that we're talking about setting up a subcommittee, a study committee that will have the scope over some of the areas.
Sure.
More that we talked about this morning. But just for, it's interesting to me, and I'm trusting and looking at the structure that this would be worked on in this committee. In Dr. Conway's letter, it references a backlog. So is there, how, as a licensing, an agency that handles these cases, how, it sounds like you triage the ones that can go directly to, and then the ones that are more complicated, is there a backlog?
So yes, there is a backlog, and I can tell you that this is where Dr. Conway and I disagree as to the genesis of the backlog. The office has had consolidated streamlined procedures over investigations for several years now. We have not followed those consolidated procedures for the Board of Medicine up until this past year when 655, 409, and HB2 were passed. And the reason for this is because the Board of Medicine had a medical review subcommittee in statute, and the medical review subcommittee was statutorily obligated and entitled to review all cases. During the pandemic in particular, and then, has it ever really ended? I don't know. But even after the state of emergency was lifted, the members of the medical review subcommittee committed to only reviewing one case each per meeting, and they met about half a year. So when you do the math and you get about 400 cases a year, that creates a backlog. And I think that is a huge part of the issue, which is why we modified the statutes last year to basically eliminate that, with the support of the Board of Medicine, we're working on creating a panel of clinicians to work with, consultants, to move these cases along, because that's not acceptable. So I think we disagree on the reason behind the backlog, but we agree that there needs to be a solution. The solution is additional resources that we're currently working on implementing, but we're only 8 months out, so.
Agreed, understood. Thank you, Director Courtney.
Of course. Thank you for your time.
Thank you. Nina Gardner.
In my private life, I'm the chairman of the New Hampshire Judicial Council and had served as executive director for 24 years. When I was retiring, Governor Lynch asked me to serve on the medical review subcommittee of the Board of Medicine. So I served on that committee for 5 years, and then subsequently Governor Sununu asked me if I'd be willing to move up to the Board of Medicine. So I've had the same kind of background as some of the other people who have spoken. I can tell you that it has been a privilege as a public member to serve on this board. It certainly is important, and I think for me particularly as a public member, I believe my job is to protect the public. And so the Board of Medicine, which is meeting right now across the street over at the OPLC, asked us to, Jonathan Edinger is here, who is president of the board. We are here to speak in support of the bill with a sense of modification, and that is that a lot of what you will be looking at, as Lindsay Courtney said, has now shifted to OPLC. So some of the processes that you may want to make changes with will have to fit into the overall scheme of OPLC. We believe there are needs for more resources. I mean, one of the things, we're a board with some significant backlog. They are working hard to try to work through that. But state government is, from my past experience working for the state for 25 years, it has some slow spots in the process. And getting these expert doctors put online, getting them through governor and council as independent contractors, has taken some time. That is an important part of what has to be there for the Board of Medicine. As a public member and somebody with some background in sort of legal process, I can get through some of the basic cases, but I rely on some medical person to tell me whether there's a medical issue in these cases. You can sort of see some of it, but they know if it's an issue of quality of care. And that is not a legal standard necessarily. So having access to those experts is certainly vital to the process. You have to understand that the whole stories behind the CMC issues, in many instances, those were cases that were privately settled outside of the legal process. Those were private, confidential settlements. Those do not get to the Board of Medicine by any measure we have now. If you think that's what you want, which is what I think the bill started out looking at, what do you think the public should have access to or not? That is probably the most important question that is out there. But you need to put that now into the context of OPLC, because that is not strictly, the Board of Medicine is not strictly a standalone operation anymore. We, as the Board of Medicine, are very positive about wanting to contribute to open transparency. We want the public to know what they can know. Not sure what they should know and what they shouldn't. That has been spelled out both in rule and in statute. So we wanted to convey to you certainly our willingness to cooperate in any kind of review of the process, but also urge you also to consider the need for resources going forward if you expand further investigation. And I too would be glad to answer any questions. But it's great to be on the Board of Medicine.
Any
I take it
questions?
very seriously.
I do have one question. I have a couple questions. One, have you noticed when did they take the limit of one case per meeting away?
I have no idea, because the Board of Medicine managed quite easy. I can't say easily. We met for over a year on Zoom. We never missed a meeting. We moved forward with the work that was in front of us. The MRC did not do that by their choice. And I think there were real questions of how somebody could have forced them to meet. They made that decision. When I served on the MRC, I can tell you it was an enormous amount of work. And many months we were moving 35 and 45 cases a month through the MRC. So it was working. Okay. The fact that they did not meet during the pandemic certainly was problematic to all of us. We would say, there are no cases. How come there are no cases? Why aren't they meeting? We were meeting. Zoom for 15 months or whatever it was for 7 or 8 hours a day is fabulous. And we kept up with the work that came to us. But for the Board of Medicine, we can only act on what gets to us, other than applications and rules and things like that.
And how many cases are you dealing with now at each meeting?
It varies from meeting to meeting. I would like to say we're probably seeing coming through in the past couple of months, 25 or more a month. I mean, they're trying to move some of the backlog through. But there is a process that you've got to sort of gather some information and investigate. And I can assure you, even in the current situation, if we see a case where we look at the investigation that's come to us through enforcement and think that they're just looking at the sort of the legal aspect of the statute, which is part of the stuff I know. But if we have a concern that there may be a medical aspect that they're missing, we send it back and ask for further investigation. So it isn't like we're just trying to move it along. We're trying to balance the need to move cases forward because there's some old ones, along with the fact that we need to get it right for the public. And I think that's what my other public member and I say all the time. We're here for the public and need to make sure that those cases are getting true value in what you, I think we're doing.
Thank you.
You're welcome. But resources for OPLC, I will be here to chime for that anytime you need me, because our work can only happen if they get the stuff to us.
Okay.
Thank you.
Any other questions?
Thank
Seeing
you.
none. Thank you. Nina, oh,
Yeah.
or, never mind. And did you say Dr. Nick Parentsevich is? Okay. So, is there anyone here that would like to speak on House Bill 322 but was not given the opportunity? With that? Sure, Representative
Representative
Pearson.
Pearson, can I call you back up and ask you a question? Thank you, Senator Birdsall.
Just for the record, I have a hearing loss and the white noise in the room is not good, so
I have no problem projecting.
thank you.
This is true.
My, so Representative Pearson, since we are studying the Board of Medicine and looking at the current composition of the board, which Nita Gardner helped me to like kind of find my way there and think about this. Is there any, I'm just trying to see where it might fit in here. And this is not about the investigations, but about the composition of the board. You know, it says physician, surgeon, physician assistant, osteopathic physician, surgeon, commissioner designee, physician, surgeon, public member. So here's my question for you, with the exception of Emily Baker, who's from I know her from DHMC, obstetrician. Is there thought given to when the appointments are put into, someone's appointed to the Board of Medicine, do you look at like how that we have some, say, different specialties that are on the board? So general surgeon, cardiologist, like emergency medicine is a big interest of mine. I hear that if we take investigations aside, that there is looking at a mechanism to bring in specialty, but I'm just looking at the composition of the board, and I don't know until I start scrolling through the backgrounds. Should there be consideration given to having, you know, a broad base of, you know, I would say a broad base of specialties on this board?
I want to get the job done, and if that means additional people are appointed to this board, okay. I would fully intend, should I be on this board, to invite those people to be an integral part by bringing testimony and helping us mold and shape things. So yes,
Okay, thank you.
however you wish to do it.
Oh.
You know,
Okay, fine.
this bill started out a long time ago, as you well know, and things change. And certainly with some of the good reforms at OPLC, we would be working much closer yet than I had first anticipated, since we could be setting a precedent for other organizations in the state that they look after.
Right, and
Go ahead.
it's been my experience with at least one of the state boards that I've been involved in that they were very specific, like, you know, pediatric trauma surgeon, adult trauma surgeon. I mean, so I know that that's a higher level of detail, but I'm just interested, and I'll have to go back and scroll through. Now I know who Nina is, and I obviously know who Emily is, and Dr. Ballard is. but I'm interested in the backgrounds that they bring to the board and whether that should be considered in the construction of all of this.
Well, whether it is an amendment from the Senate that would add specific categories of people to be appointed, or people that are brought in as regular witnesses, I think the effect would be the same. We would want to hear from all kinds of different folks that have reason to speak to us.
Okay. Thank you.
Welcome.
One question I do have for you. Seeing how many people are on the committee, wouldn't you say this is more of a commission? And if we're going to be adding more doctors on it, should it be a commission?
Senator Birdsall, I think so. Even though I'm hearing what Representative Pearson's saying about who they can bring in to testify and participate in the forum, I'm actually scrolling through and looking at the current Board of Medicine and thinking about like what kind of disciplines are represented there.
Yeah, but that's a board of medicine. This is a study committee.
I
too.
understand, but since they're going to be looking at items related to the Board of Medicine and how it operates, I thought I'd find out if they had the ability to look at this at all. And they might not, and it might be for a later conversation, but it just caught my attention in looking at the composition. Okay, that's all.
Thank you.
Thank you, Representative Pearson.
You would like to come up and speak? Come on up.
Hi there. Dr. Jonathan Ettinger. I'm president of the Board of Medicine. I just wanted to piggyback on what you were saying, Senator Prentice. Right now, the demand. So I'm currently in clinical practice. I'm not retired, and most of our volunteer representation on the board is from providers that are not in clinical practice or in the public sector. The providers that are in clinical practice and participate are volunteering their time and have to get out of their employee agreements in order to do that. So over the years, the tendency has been, and this is a nationwide issue, this isn't a New Hampshire issue, the tendency is for board members to be filled by retirees, retired physicians. So it becomes very difficult to get to your point around the breadth of disciplines that should be on the board. I think it would be great. I think it would be ideal to have the surgeon, the emergency room doc. Right now we have 2 cardiologists on the board, right? So it's not great, but that being said, the board's actually being filled by people who want to be on the board and who are currently practicing medicine. So I think I like that as sort of the first designation for who wants to be on the board, as opposed to the breadth of it. I think, like I said, ideally, I think your point is well taken. I would love to have a broader distribution, almost make the MRSE unnecessary, like it is now. We'd be able to cover a lot of the specialties without having to send it out to another physician to review. But that, unfortunately, that's not the case. But we do have a nice quorum, and we have people who are actively practicing medicine, so it does work. There was another point that was made. I'm trying to remember it now. Do you remember, Nina? What was the other point? Yes. I'm sorry, I can pick up on it. The current reorganization, if we were to reorganize in a way that would make that would have less members of the board, I don't think that would be helpful. There's another bill that I don't think is part of this bill that maybe you were talking about. No, okay. This is just general. Yeah.
As Nina Gardner was talking, and I just decided to scroll through and see
I see.
like, who was on and what background. That really, I don't know anything about the other bill. It's
Okay.
It's purely organic.
Okay. The current, I would not reduce the number of members. We're coming in from all over the state, and sometimes just due to our clinical obligations, the currently practicing physicians cannot make it. So just something to think about as you're considering other bills. But thank you very much. Yep.
Thank you so much.
Doctor,
Please.
what did I didn't get your last name.
Sorry, it's Ettinger, 2 Ds, EDD. Yep.
Thank you.
Yep. You're welcome. Thanks.
Dr. Conway, one more time.
I'm Dr. Conway. I can address your question very succinctly, that one of the functions of the investigator was to determine who should evaluate this case. That There were cases that I evaluated when I was on the MRSC where, as an obstetrician gynecologist, I could address part of the case, but if it involved another specialty, radiology, I would need to bring in a volunteer outside radiologist who was not on either committee, either the committee or the board, to do that review at no cost. That it was a volunteer kind of thing. When I was the investigator most recently, I found that in this day and age, there were not a lot of physicians who were really interested in donating their time without any recompense. And I've had conversations with Executive Director Courtney about that, and I'm not sure where that lies right now. But as physicians, we recognize our limitations. If you ask me to evaluate a trauma patient or a trauma case, I don't think so. I might have an opinion, but what's it based on? So that process has existed in the past.
Thank you.
All right. Is there anyone here that would like to speak on House Bill 322 but not given the opportunity? With that, I would close the hearing on House Bill 322. You ready, Cam? All right. I will open the hearing on House Bill 1088 and welcome the prime sponsor, Representative Nelson. Welcome.
Thank you, Madam Chair, and thank you to the committee for hearing my bill this morning. My very first bill, so it's very exciting for me and nice to see all of your friendly faces. For the record, I'm Representative Jody Nelson, representing Rockingham 13 in Derry. This bill is important to me as I know firsthand how critical it is to be able to administer epinephrine to a person experiencing anaphylaxis as soon as possible. When my son Luke was 2, I fed him a peanut butter cracker for the first time and I nearly killed him. He immediately experienced a severe anaphylactic reaction, and through testing, we discovered he's severely allergic to peanuts and has varying degrees of allergy, tree nuts as well. He carries a life-saving epinephrine auto-injector everywhere he goes, as accidental exposure can occur at any time. Approximately 8% of the pediatric population has a known food allergy, and nearly 40 of those children have reported an anaphylactic incident in the past. Nearly 25% of anaphylactic reactions in school occur to those who have no known allergies. Food allergies account for 30% of all fatal anaphylactic reactions. We now have full-day kindergarten in New Hampshire, thankfully. It's great. These kids are eating in the cafeteria and they may come into contact with food that they have never experienced before, resulting in a possible anaphylactic reaction. We have visitors and volunteers to schools who may be exposed to an allergen food or a bee sting if they're volunteering outside and have an anaphylactic reaction, may have an EpiPen, or they might not have a known allergy prior to a reaction like this. Also, there are students in our schools who have a diagnosis of anaphylactic allergy, are prescribed epinephrine pens, but for whatever reason do not have one at school. So it's important that to me, and I think it should be important to all of us, that we are able to provide access easily for schools to be able to have a stock epinephrine pen available. And I want to give you an example of why this is so important for kids who are diagnosed but may not have a pen at school. My school nurse actually administered an epinephrine pen to a student with a known allergy. She had to administer 2 shots prior to the EMTs arriving at the school, and she was told by the EMT that this was so serious that the child most likely would have passed if she had not administered the epinephrine pens. So the first line of treatment for anaphylaxis is administration of the epinephrine and then dialing 911. It works immediately to stop anaphylaxis by causing I'm sorry, I have a typo there. It's a medical term, but I will just tell you the result is reducing edema and preventing hypotension and shock. And it's the only medication with rapid and life-saving results. In 2013, the Federal School Access to Emergency Epinephrine Act was signed into law. And this law allows states to pass legislation relating to stocking undesignated epinephrine auto-injectors to be used by trained staff. Presently, we do have in statute under Chapter 329, Physicians and Surgeons, 329:1-H, the ability for school nurses to obtain a stock epinephrine pen. The language is buried deep into RSAs of this section and is basically one sentence. We do have schools that do have a stock epinephrine emergency injector available. This is in practice. And I wanted to let you know that. However, my goal in the passage of this bill is to create a framework of continuity of practice and clarity on procedure throughout all public schools. It has the blessing of the New Hampshire School Nurses Association, and under the post-secondary and independent school RSAs, they do have language referring to a stock of emergency epinephrine auto-injectors, and it also makes sense that the public schools have language too, that school personnel and parents alike can easily reference. I asked OLS to use the same language that we currently have in statute for emergency asthma inhalers. That is working really well. And so I literally asked OLS to take that language exactly and replace emergency asthma inhalers with emergency epinephrine auto-injectors. And again, the School Nurse Association is in favor of this bill. They like this bill. I wanted to just let you reiterate that they are able to, and it is in practice in schools, that they do have a stock of an emergency epinephrine pen. There is training on how to recognize and how to administer this type of medication, recognize an anaphylactic reaction. There already is in statute how to maintain and store epinephrine auto-injectors, because so many kids, like my child, has one in the nurse's office. Also too, there is in statute the release of liability. All of those things are already in statute and in place. I just wanted to let you know this bill would not change any of that. And also too, there were questions in the other committee on the other side about those issues. I just wanted to let you know that all of those can be found in the just one moment, in chapter 200, health and sanitation, pupil use of epinephrine auto-injectors. I also wanted to let you know that should we pass this bill and it becomes law, It will make it much easier for school nurses to obtain the stock EpiPen. And we have another speaker here who will elaborate on that. So I'm not going to waste your time by giving you double testimony on that. Because he will be explaining that further. I also felt that it was important to make sure in this bill we had language that allows for a donation to be allowed to obtain this emergency use epinephrine auto injector, because right now our schools utilize a program from a pharmaceutical company that gives schools free epinephrine auto injector pens. However, if there's a time that's no longer available, I wanted to make sure this wasn't a burden on the taxpayers. I know I had been on the PTA. We had raised money for the AEDs that are in a lot of the schools now. So I cannot imagine that would, if there would be a time that the PTA would not consider it. And I certainly know there are enough of us parents in the allergy community that I would be confident that we would all step up and donate. So that would be something that would be maintained in the schools as well. And I think that's, all that I have for you at this time, and I would welcome any questions.
Senator Prentice.
Thank you, Senator Birdsall. Thank you, Representative. Nice job. So here's my question for you, if this is something you'd be interested in working on. First of all, I'm a paramedic. I understand the seriousness of anaphylaxis, and I appreciate your advocacy to making these pens more accessible in all corners of New Hampshire. So, very important. So, on a different note, I worked on a bill a few years ago to put emergency action plans in place for school sporting events. Follow me here. And when the bill came over, I'm taking this kind of left and I'm going to bring it back in. When the bill, one of the things that we amended the bill to do was just a very little line that said, you can, having this plan, good, go, but can you make sure that you coordinate or you have a conversation or collaborate with the local EMS squad so that they know that you've got this supply, they've got their supply, everyone's on the same page when these emergencies happen. I mean, it tends to be in the smaller communities that there's a lot more of this collaboration. So I was just wondering if you'd be open to, I put a little language in, maybe we could work on this. I don't think it's a hill for me. If we can't do it, I'm fine. But if we could just add language in that, possessing the supply, the auto injectors, pursuant to the subdivision, you have an annual report. We just require that they touch base with the head of the local ambulance service about their stock and their and it'll bring more collaboration along the response to anaphylaxis too. I don't think it'll get in the way of what you're trying to do. I think it'll only help it.
Thank you for your question. I would definitely be open to that. I would, if respectfully, ask you to allow me to ask our school nurse, who's also the president of the New Hampshire School Nurses Association, if that is something that would not interfere with anything else in the bill. But I think that I think that sounds like a great idea. And I guess it would maybe only be like a correspondence, like a letter or an email that would be required. Is that what you're thinking about?
It could be a letter, it could be an email, just making the formal connection. Any place we can elevate these relationships in response to emergencies, it's good.
Thank you.
Thank you. Right.
Any other questions from the committee? Seeing none.
I'm sorry, Madam Chair. I have one more thing, if I may. There is a housekeeping amendment that I was made aware of yesterday and then this morning that will be presented. I actually have another bill that I need to leave for. I apologize if you see me leave. That's why. I just wanted to let you know that I'm okay with what this person will be testifying about. Thank you.
Caitlin, Caitlin Katab is in support and says she's speaking. No? Okay, I'll bring someone else up. Morgan?
Good morning. Thank you to the committee for listening to my testimony this morning. I am who Representative Nelson was referring to, speaking about the national donation program for schools that utilize EpiPens. I'm with a company called Convenient MD. We have urgent care and primary care locations throughout New Hampshire. And one of the things that we do for schools as just purely a way to give back is we help schools through our school nurse partnership program. One of the elements of this program is we help schools obtain stock medications. Again, we don't charge any fees. It's purely a way to just give back to the community. Many schools in New Hampshire reach out to us for assistance in utilizing the EpiPen for Schools program. It's a national program that donates 2 boxes of EpiPens to schools at no charge. They require a prescription for each school. For the stock EpiPens, and so that's where we come in. We help schools. We get the prescription written. We help them place the order, and in New Hampshire, they are shipped to the prescriber to then dispense to the school. In most other states in the country, they are shipped directly to the schools, including Maine, Massachusetts, Vermont, our neighbors. The reason that they are not shipped directly to the schools in New Hampshire is because of the way that existing law is written, because the facilitator of the program is licensed as a wholesaler. The language of the law is very specific and says wholesalers may sell medication, but because it does not expressly permit the donation of medication, the Board of Pharmacy told us that is why they're unable to provide it directly to the schools. And so because it has to be shipped to the prescriber first to then provide to the school nurses, it creates kind of an inefficiency. It requires school nurses to drive on their own time after school to go pick up the EpiPens. Sometimes for more rural parts, I mean, these school nurses are driving quite a distance to come to the nearest location. Sometimes there are issues with things getting misplaced, and it just creates an extra step in the process. So what this bill would do is I have reached out to the facilitator of the program and said, can you confirm that the language would be good to allow, to ship right to the schools? And they said, yes, it would. Again, like I mentioned, this is how it is in most of the other states in the country. There are just a handful that have little quirks, or what I would call a quirk, I should say, in the law that prevent it from going right to the schools. And just to reiterate, it is school nurses do utilize the EpiPen for Schools program already. This wouldn't be something new. It would just simply make it easier for both the school nurses and the prescribers to utilize the program. And potentially it would open up the door to more prescribers that might be willing to assist schools, because if all they have to do is write the prescription, that's one thing. If they have to write the prescription and receive the order, manage it, and then, dispense it to the schools, that's a little extra burden. So I would take any questions if you have any.
Any questions? Seeing none?
Okay.
Thank you.
Thank you.
Representative Katab.
Thank you, and thank you for having me here this morning. For the record, I'm Representative Caitlin Kutab from Windham. I just wanted to speak very briefly. First, this was already on the books, but it was in 2 places, and during a cleanup, I think it was accidentally removed from both places in some really large bills. So this is just putting one back. Senator D'Alessandro had worked hard on this concept a while ago. I think it's really important. My daughter has a tree nut allergy. We didn't know she had a tree nut allergy. She was eating some Nutella with my father-in-law, and I heard her from the other room going, Cito, my mouth is itching me. And I'm like, what? And I walk out and her lips are blown up, and I carry her upstairs to my husband, and by the time we get up the top of the stairs, her eyes are swollen shut. And it was just so fast. And thankfully, we had an EpiPen in the house. We were able to give it to her and immediately drive off to urgent care, although we should have probably gone to the ER, but urgent care was closer. And she was okay. But you don't know until you know. And then all of a sudden, you've got a child that's literally in a life or death situation. And in some of these towns like Windham, for example, the
the fire department is at least 10 minutes away. And by the time they get there, it may be too late for that child. And they may have eaten something for the first time that they had no idea they were allergic to because we had no family history of it. And it just happened. So I think it's a really important bill, and I hope that you all support it. Thank you.
Thank you, Representative. Any questions from the committee? Seeing none.
Thank you.
Last speaker on this is Elizabeth Sargent. Welcome.
Hold on, I always go to the left. I don't know why that might have been bad luck. I always do things the same order. I don't know why I just did that. Good morning, Chairman Bertzel, members of the committee. My name is Elizabeth Sargent. I work for Champaign Capital Group here representing the New Hampshire Pharmacist Association and the New Hampshire Society of Health System Pharmacists, pharmacists in hospitals. I'm here to testify in support of the bill. We were just asking for a belt and suspenders amendment. This House Bill 1088, it allows in Section 3, a pharmacist may dispense. It allows them in an education statute. So the pharmacists were just thinking if they could add it to RSA 318, which is their statute, which is page 2 of your attachment. So, and it would dovetail nicely here because here is where the nurses are allowed possession and administration of epinephrine for emergency treatment. And we took the liberty this morning, I added the broncholitis statute because it's exactly the same. So we would suggest maybe a new D and E or however OLS wanted to do it. I know they are allowed to dispense in a couple different areas, actually. It was pointed out another statute this morning plus this, but we think if we just put it, the pharmacists go to 318. This is their dispensing statute. So this is where they go. So if we could add it here as well, belt and suspenders, and I think that's all I would have to add for your consideration.
Any questions from the committee? Seeing none.
Thank you.
Is there anyone here? That was the last speaker. I have Ben Bradley, not wishing to speak, but in support. Is there anyone here that would like to speak on House Bill 1088, but was not given the opportunity? With that, I will close the hearing on 1088. And when Cam is ready, we'll open the next hearing. Yeah. I have 302 here. I know. Okay. Does anyone? We don't have enough people to exec, so. What time is it? I have no idea. Do I hear a motion? I'll second. Senator Award seconds. All those in favor of exec session, say aye.
Aye.
Opposed? Okay. Why don't we pull Senate Bill 403? And I'll second. Any amendments, any discussion? Okay,
Which I'll move on to pass on amendment 888. I'll move on to pass on amendment 888.
Second.
88888. This with date of February 29th on it?
Leap year date.
Look at that.
I don't have, okay.
All right, so
Oh,
can I walk through this?
Please.
absolutely.
All right, so this is a pretty significant bill. And a lot of changes in it. So first change is in the purpose statement. I eliminated sections 2 and 3 from the purpose statement, but I added lines 14 and 15. There's been a big debate about the role of case managers. We have a case manager here today, and how they would intersect with the community health workers that are proposed to be certified later in the bill. If you go to the bill in section 4, we had testimony with that section about adding the words on line 31 about service coordination from the department, that they were concerned that they would lose a lot of federal FMAP funding, the Medicaid matching funds that they'd have to repay because we'd be changing definitions. So the department wanted that entire section out. Then the department got back to me and proposed a working group to try to settle some of the controversy about case managers. The case managers were not real thrilled with the idea of a working group. If you remember that this was an issue that came up in Senator Gannon's bill last year, that we negotiated a compromise. So it's probably going to be an ongoing discussion in the future. So the reason for the purpose statement is to make it very clear that case managers play a critical role doing what they do, and that their role should not be supplanted by a new category of community health workers. I'll get to another piece in a few minutes on how this impacts case managers. So section 2 of the amendment is the same as the bill. Section 3, same. There was no controversy on those. Section 4 of the bill deleted. So we go to the community health workers and the certification process starting on page 2. I don't think there are any changes until we get to page 5. So in the bill, on it, that section in the amendment, Roman 3, which is on page 5 of the amendment versus Roman 3 on page 6 of the bill, the word certified community health worker, the word certified is taken out. The certification process for community health workers is meant to be voluntary, so it shouldn't be mandated. That was a request of one of the caseworkers, so I've tried to accommodate that. And as was explained to me by another caseworker, a phrase in line 10 and 11, or that whole sentence starting on line 9 of both the bill and the amendment, while engaging in the practice as a community health worker, an individual shall not engage or perform any act or service for which another professional certificate, i.e. a case manager, is required. So there is, in this amendment, meant to be protection for caseworkers. I suspect that this debate will continue, but I think for now, in terms of sending a strong message from, you know, the legislature about the critical role that caseworkers play, we're doing that. All right, so moving along in the amendment, the telemedicine section is the same, and then we get to the appropriation sections of the bill and the amendment, which is on 7. So the fiscal note of the bill, and if you just add up the appropriations in the bill, I think it was $32 million. I have eliminated all of the appropriations, but the language that in line 7 of page 6 of the amendment allows the department to contract with community-based organizations, including health centers, family resource centers, to deploy and sustain community health workers. So it allows the existing process that was funded by ARPA funds to continue. It would allow them to use federal funds where available and general funds within the department's budget as approved by the fiscal committee. So we had testimony that there are some of this category of community health worker that has been paid for with ARPA funds. The department should have the ability, if ARPA funds run out before the next budget, to be able to use this section to go back to the fiscal committee and ask to move money around. I've run this language all by the department. There's nobody here from the department, but Kate talked to Henry Lipman, and I think they are okay with it. And then obviously we ask that the department develops a plan for funding alternatives, and it's part of the budget submission in the next year. Section 8 is the same. It allows Medicaid reimbursement. So the one question I understand from the sponsor of the bill was about the effective dates. So the reason I made January 1st, 2025 is to give OPLC time to set up the certification process. So if the committee wanted to have a committee amendment to make all the other sections of the bill effective on passage, I think that would actually make sense. And I do think that section 6 of the amendment should be effective at whether it's 60 days after passage or January 1st is probably a good idea. Thank you.
Senator, was that the only question the sponsor had?
She hasn't talked to me. It was Senator Rosenwald, obviously. I saw her in finance yesterday. She didn't say anything. So Kate, I think, talked to her.
Okay. Yeah. Thank you, Madam Chair. So yeah, I did speak to the sponsor as well and supportive of this effective date change, and I think she's grateful for that, and for the changes regarding the case management. But it has to be said that, you know, Senator Rosenwald is very disappointed that the funding was removed, and I share that disappointment, particularly when there's just, it's such a massive issue, and to remove any funds, I think, is a missed opportunity. But we're continue to work on it both this session and next session.
Well, I appreciate that. I think that some of your other bills, in my opinion, have a higher priority, like Senate Bill 499 and Senate Bill 407.
We shall not pit
So,
priorities
you know,
against each other.
I'm just saying. I'm just saying. And they come with a smaller price tag. Thank you very much. Thank you very much.
Pam, did you get those changes?
So what I have is section 6 shall take effect January 1, 2025 The remainder shall take effect upon passage.
And that would be a committee amendment, yes.
So I'll second that committee amendment.
Where are we now?
Amendment 0888S with the committee amendment changing the effective date has been moved and seconded.
Are we done with discussion? All those in favor of amendment and committee amendment, say aye.
Aye.
Opposed?
Move ought to pass as amended.
Second.
All those in favor of ought to pass on amendment as amended on 407, 403, say aye.
Aye.
Opposed? Do we want consent?
I'll
So
move consent.
If it goes on consent, I'd like to write the blurb because I will, Cam can write the blurb, but I want to make sure that some of the language on case managers is part of the blurb to create the legislative history.
Do we
So
want
there's
to?
no question about it at all. No, we go on consent.
Consent. Second.
I moved it.
All those in favor of consent on 403, say aye.
Aye.
Opposed? And I'll, do you want to take that?
Yeah.
You seem to do the blurb.
Oh, okay. Because he doesn't have to come, he doesn't have to speak to
I
it.
don't have to come down on the floor as long as somebody doesn't remove it.
Uh,
Well, that was easy.
302. This was Senator Rosenwald's other bill, which exempts from the application of the chapter of physician licensed in another state, basically telemedicine. And I know Bob Dunn had come in, but I just spoke with him before we started. I will do what I did last time his concern was assisted suicide. If it's legal in, let's say, a state that the telemedicine doctor is in, can he or she authorize it in New Hampshire? The intent, I think, is no. What's not authorized in the state, the telemedicine doctor cannot authorize the patient. So I will ask the question to Senator Rosenwald.
Okay.
And have her answer.
So,
I think that's a good idea.
so there's no motion one way or the ought to pass or not? Were you gonna wait on something or?
No, we're going to. I guess I should have waited. I move ought to pass on Senate Bill 302.
Second.
Second.
Now discussion. So
I do that all the time.
I will ask the question on the floor to clarify that. So, we are ought to pass. All those in favor of ought to pass. Any discussion on 302 other than what I just said? Nope. All those in favor of ought to pass on 302, say aye.
Aye.
Opposed? All right,
So no consent, so you can ask the question.
exactly. So,
You wanna take it out or you want me to take it out?
why don't you take it
I'll
out
take it out.
and then. So I can ask the question. I'll ask Senator Rosenwald to speak on it, and then I can ask her a question. 407, Senator Prentice, did you want to go through yours?
Sure, I'd be happy to. So we have Amendment 0540, actually dated earlier in the month because I have been holding on to it. And so what this does is it amends the initial version
Do we need
to,
ought to pass or before we?
I'm making a,
Yeah.
I move ought to pass on
I
the
second.
underlying bill.
thank you. Okay, so what this does is, the purpose of the direct pay bill is to get the payment from the insurance carrier for the service directly to the ambulance and to take the patient out of the middle, getting that check and anything that might go along with it. That is the purpose of this. Okay, that's strictly what it is. The only other piece that's changed is it allows for the rate basically for the rates to be set by the ambulance service. So it doesn't get in the way of any contractual relationship that might already exist. But in the absence of that, the payers need to pay the ambulance service for what they charge for. And I think it's important to remember here, number one, that we don't ask hospitals and get in the middle of what they determine their charges are for the care that they provide. The same needs to be applied here. If you are Hollis or you are Hampstead or you are Wolfboro, Hopkinton, or Lebanon, we figure out how we want to deliver emergency medical care, what it costs us to do that, and then we have to find a way to pay ourselves back for that. Part is from the taxpayer, the other part is from the insurance carriers. Beneficiaries are paying for the service, so we just need to align this. We heard testimony after testimony from folks, and I provided examples of communities that have a gap because these bills have been paid directly to the patient, and they for whatever reason, including confusion, it doesn't get back to the ambulance service. So we can eliminate that. We can help to be one of the solutions in stabilizing emergency medical services in the state. Thank you.
I second 0540.
Well,
Nobody seconded it, so
oh,
I second
okay.
it.
Thank you.
And we already had our discussion.
We have the bill bill and then the amendment. Okay.
Have you talked to the insurance carriers?
Insurance carriers,
Are they,
over the course of time, yes, I'm not sure that they completely agree with this solution, but they are already paying the bill. It's just who they pay it to, and it's not all insurance carriers.
should I,
We can't completely we just need,
Okay.
this is passing in other states. They're already paying the bill. They need to pay the bill to the ambulance service, not to the patient. That's the purpose.
Senator, it's come
Yes.
to my attention there are abuses in the way the system is set up right now. Is that correct?
In terms of,
Senator, say that again?
yeah, say it loud and give me an,
There's abuses from what I understand of how the system is set up right now, where somebody can call in and they can make a lot of money off this, calling in the ambulance over and over and over again, or something to that effect.
so you've been given examples of patients that have used this as a way to get the payment to themselves and not pay the ambulance service. I understand that does exist, and I've been given some examples.
Yeah.
So I think all of these things put it outside of where it really needs to be, the people who provide the service.
I'm good.
okay. Where are we?
All in favor of the amendment?
Did you get a second on your amendment?
I
You're not the
seconded
chair,
it.
sorry.
He
Oh,
seconded.
he seconded it. All right, thank you.
Top of this thing.
I introduced it, you seconded it.
job.
Thank you.
All those in favor of amendment 0540S, say aye.
Aye.
Opposed?
Move on to pass as amended?
Second.
All those in favor of what to pass as amended on Senate Bill 407, say aye.
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 Opposed?
I move consent.
Second.
I'm afraid.
Okay.
You all right?
You seconded it, so. all in favor.
All those in favor of consent, say aye.
Aye.
Opposed? Senator Prentice, you want to take this out?
Yeah, I might be happy to. Yes, ma'am.
Is there any, I know you wanted to talk about Senate Bill 411.
Yeah, Madam Chair, thank you so much. I would love to discuss Senate Bill 411. I don't think we need to vote today, but there are a number of people here who have worked very hard to get where we are right now, and I just wanted to have the committee be updated, and maybe we could start with the commissioner if that works. And Michelle, I didn't mean to exclude you.
I never leave my brains at home.
There you go.
Good morning.
Puppy.
Oh, boy, let's not talk about that.
I know a good cleaning company.
Oh, well, good morning, everybody. DJ Betancourt, Commissioner of the New Hampshire Insurance Department, joined by Michelle Heaton, I feel like at this point I'm almost an ex officio member of this committee. Um, very pleased to be before you today, hopefully also before you as a draft of the bulletin that the stakeholder group on Senate Bill 411 worked very hard to.
I apologize.
together.
I
It's okay.
don't think the committee has the bulletin. We will get
I know
it.
it was emailed.
Yes.
Yep, everyone got
Okay.
it emailed to them yesterday at 2:30
Perfect.
p.m.
Perfect. Cam is way ahead of me. I did not do it, but Cam did.
No worries at all. So first and foremost, I do want to thank all of the stakeholders who worked incredibly hard. And equally as important to the bulletin that's before you is that we learned a lot in this process. It really was a very, very fruitful exercise, at least for us, and I think for all of the stakeholders as well. So broadly speaking, and we can obviously get into as much detail as you'd like, but broadly speaking, the bulletin does 4 big things. First, it clarifies the codes to be used for the particular services. So as you may recall in Senate Bill 411, you had some broad categories of services that you wanted to see covered. What we did is, as I promised we would do, is we looked at those broad categories and we said, okay, within those broad categories, what are the specific services within them? And then how do we match that up with a CPT code to better allow and better educate the providers as to what codes they should bill for those particular services. So we did that, and there's a wonderful matrix that my team put together for you to take a look at. I take no credit for this, but I will say, out of pride for my department and my team, we really did in this exercise under promise and over deliver. Because when we first started out, as I said, the main exercise was marrying those codes to those services, but we took it a step further and did some other really important things. So in addition to those codes, we also clarified what types of providers are able to bill for those services. And that's also reflected in the matrix. We further encourage the carriers to contract or to update their contracts with providers to make it very clear that they should be offering the services that we're talking about here. And then finally, it encourages all of the parties to explore alternative payment models that could perhaps work much better for both providers and carriers. So those are the 4 big things. I will be candid with you. It's not perfect. It's not perfect. And I will say that on the happiness scale, I don't think anybody's unhappy, but the providers are somewhere along the scale of happy. But we still have work to do. And I want to be honest with you about that. I think that for the timeline we were working under and for the statutory authority, the regulatory authority that we have as a department, I think we have made great progress. But I do acknowledge that we've got more work to do. And I just want to briefly share with you and make some commitments to you as to what that means, what that is going to look like. So as you know, we recently as a department refurbished and brought back our Behavioral Health Advisory Committee. I have made it clear to the providers that I would like to see them there. I'd like for them to participate, and I'd like them to keep us updated on how things are going, how the bulletin is being implemented. Do we need to make changes? Do we need to engage in further education? There's going to be that consistent forum for us to get that feedback back from both carriers and providers. And if we need to make adjustments, the beauty of a bulletin is I can make an adjustment and get it out the next day, and it has the effect immediately. So that's how we're going to continue to work on this. We're going to continue the dialogue. There are some issues that I know that the providers still want to see addressed. We're going to figure out how we do that. But as I said, I think we've made some really good progress here. I'm very, as I said, pleased with the collaboration and happy to answer any questions.
Thank you, Commissioner. Any questions from the committee?
I want to thank the department and all the stakeholders. There have been an incredible amount of work and collaboration. I think we are further along than we were with the prior iteration of this bill, SB 70, because of what the commissioner identified as, we have a sense of the various codes at play here. And then what the second sort of part of this issue was, making sure that's great if we have codes, but we have to have providers to actually provide the service. So kids actually get the service. And I think we are further along on that. I think the area that is sort of outstanding is this issue about the Fast Forward program. That is the program on the Medicaid side that keeps kids out of hospitals, that keeps kids out of high-end needs. So it's both effective and it's cost effective for the state. So we still have kids with private insurance who are accessing that and the state's paying for it. So I think that's an outstanding issue that we want to continue to explore. I know the commissioner is facilitating educational conversations around that because it is new for private carriers to cover that type of bundled service. I ask that we don't vote today because I think there's some questions about keeping the bill a little alive just to make sure everyone continues to stay at the table because we've made such rigorous progress. So I'm wondering if we also want to have new futures come up and sort of talk about where we are on the provider side, if that would be helpful too. But again, I want to thank everyone for the incredible work that's gone into this.
Thank you, Commissioner.
Thank you.
Thank you, Michelle. Appreciate all the work you've done. New futures. Welcome.
Thank you, Madam Chair. I don't have much to add. I think that the department did a very good summary of where the discussions are. And it is accurate to say that not everyone is quite happy at this point, but I think that we see a path forward and do want to make sure that the momentum is kept up, because it is true that you still need to go through the process of engaging in contracting and seeing how those contracts ultimately are negotiated and developed. We do share the concern and had articulated that concern to Senator Whitley that the care management entities in particular need to see, I think, a bit more of conversation with the carriers and how they are going to be contracted. And DHHS, if they need to continue to backfill certain services because they're parsing things out of that service array, we need to have a number of what the CMEs are still going to be able to expect to receive to be made whole. So that's sort of where the rub is right now, is that Fast Forward and the High Fidelity Wraparound Program is an array of services. And so when we were looking at specific codes, there are certain things that are not necessarily typically covered by insurance. We need to figure out how we can continue to offer those to those families in a way that makes it possible for the CMEs, the care management entities, to offer those programs the way that they're designed to be delivered, that they're not getting bits and pieces that are paid for by private insurance, and then there's like a spattering on the side that continues to be the responsibility of DHHS. If that is ultimately what the scheme looks like in order to make it work, it needs to be something that is not overly administratively burdensome for the CMEs. So that is a piece of the ongoing conversation that needs to happen, that we remain concerned about. And so, to Senator Whitley's point, we would like to see the bill continue to be kept alive so we can monitor this progress and see if we're able to figure out, what do bundled rates or alternative payment models look like for these particular entities? How is that actually working? So that we can see the results. Essentially, at the end of the day, I think we all want the same thing, and it's for privately insured kids to have access to a full and robust array of children's behavioral health services. And we've made great progress, but we're not quite there just yet.
I appreciate what you're saying, but remember, it is an FN, so it has to be out of here on March 28th regardless.
Yep.
So at the latest.
So we had discussed some options to potentially keep the bill alive if it were to pass off to the next committee. So we would be open and willing to have conversations about how we may be able to amend the bill to keep it going for a little while the group continues to do its work.
Okay. Any questions from the committee? Seeing none.
Great. Thank you.
Can we hear from Sabrina?
Sure. Absolutely. Come on up, Sabrina.
I just wanted to note that I think part of what came out of the meetings is the fact that, as far as I can tell, none of the care management entities are in network with any commercial insurance companies. And so if they're not in network, then they can't bill for the services. And so I think a really important point is that the carriers have to actually have the conversations with the care management entities. I've reached out to at least one of them to start that conversation, because you actually have to have the conversation to bring in our BH folks and then bring in our contracting folks to actually get them in network. So I think that's like a really key piece, and it's not a super fast process, but that is something I think that came out of the stakeholder meeting. So thank you.
Any questions from the committee? Thanks, Sabrina. Go ahead.
So, agreeing with Senator Whitley, going back to when you and myself and Senator Sherman, started these discussions, I think we've come a long ways. I think there is broad agreement by the carriers, the providers, the insurance department, that the Fast Forward program has worked for the Medicaid population, trying to make it work for people that have private insurance is important. I think we would all agree on that. So, hats off to everybody that has worked hard to make it happen like that. I think that there are probably procedural ways that we can keep the bill alive, even if it only turns into a study committee on the Fast Forward program. That would be a way to proceed, I think. So a lot of good work's been done. I remember sitting here, 2 months ago, and saying DJ cracked the whip. You done good.
And he did.
And everybody is, the carriers have come to the table. I think it helps the carriers in the long run, helps, the kids obviously in the short and long run, and the insurance department's done a really good job. So I think kudos to everyone.
All right. The only other one I wanted to is, are there any others that anyone wanted to talk about right now? Huh?
Yes, Senator Perkin Quokka's IVF bill.
Yeah,
She-
she has an amendment.
Yeah, she continues to have robust conversations with the carriers, but they're not ready yet.
Okay. Yeah. Okay. All right. The one I wanted to talk about is the one we heard today, the first one, 322. I don't know why it's sticking in my crawl, but to me, a study committee is state reps and state senators. I think this bill is establishing a commission. I don't know. What are your thoughts?
Because it's a study.
I know, but there's 12 members on it, and then,
Walks like a duck and it quacks like a duck. It's a duck, it's a commission.
You opposed to it being a commission?
I can talk to him. He's one of my state
Yeah.
reps, but, and
Senator Burnsell, the other thing is that if you go with a commission, then if Representative Pearson and you decide that's the direction you want to go in, instead of just, page 2, line 3, that section line 3 through 11, those different organizations that are named like to be invited to come speak, but not voting, could actually become, permanent members of the commission too. Like you could broaden the voice and give them voting.
oh, I see.
Yeah.
So. No.
We wanted to change it to the one senator as well.
Yeah, they want it, we want to drop it down to one senator. So basically, the people that he's talking about here, to ensure a breadth of expertise, the following shall be requested to be in regular, attendance, but shall not be voting members of the committee. I don't know. Let's think about it. I've never seen a committee with, non-voting members.
No, it's happened before.
Has it?
Yeah, it's happened before, but this looks to me like Representative Pearson wants a commission, and it should be a commission, if that's what he wants. Not a study committee.
And then you, Senator, you wanted to add a few more doctors in there.
Well, I don't want to add them to the committee, may soon to be amended to be a
Sounds like
commission.
she's also volunteering to be on this committee.
Oh, yeah, I would be very interested. But what I just noticed in looking at the Board of Medicine when we were in here, and I don't know so much that I want to, I mean, this is where they could actually look at what's the composition of the Board of Medicine? Is it well represented of different disciplines? Do we need to keep a smaller number or do we need to keep a larger number? Now, I hear that they bring in investigators for specific complaints that are more specialized and that the board itself is more broad. But I have to dig into each one of these. But we did hear there's 2 cardiologists, and that's great. But maybe there's a cardiologist, and again, is there an emergency? The Board of Medicine deals with, pediatrics, cardiology, general surgery, emergency medicine. I don't know if there was a way to just even look at that and see if there's a recommendation to be made. That was all I was trying to get at, like not who you should add to the committee. I think Representative Pearson misunderstood me, so I tried to clarify it a little more, that would this, and I heard it would, give them the opportunity to discuss what the current Board of Medicine looks like, and if it is, when they seat people, are they seating broadly versus who's available? I did hear in testimony of one of the, it was the last gentleman to speak. He said it's, that would be great, but they often go for like who's available versus, and I can respect that to a point, but I think that, it would be smart to do your best to make sure that you are, again, broadly representing the medical profession.
So do you want to add to their duties to review the medical board, the members of the medical board, and
Probably should talk.
yeah,
I mean, I think item B under 3 might get there. If it's okay, if we're gonna wait on this, if I can talk to maybe 1 or 2 of the, talk to Director Courtney, talk to the Medical Society and the current chair of the Board of Medicine to see if there, I mean, it seemed like there was an clearly they understood what I was talking about. I didn't feel it was big pushback, but I just want to, if this already does the trick, I just want to make sure that they examine it. If we need to be specific, those are the 3 entities that I'll ask. Does that sound fair?
yeah.
Okay, we'll do.
And I'll talk to him about making it a commission versus a committee.
Yep.
Senator
Thank you.
Bertzel, Representative Pearson also wanted to add a 5th member of the House who's not assigned to any committee so that he can be appointed. Just wanted to put that
Yeah,
in
I've got,
discussion.
yeah, that's on his amendment, so, okay. Anything else we wanted to discuss?
Motion to move out of exec?
I'll
Second. Oh, sorry.
No, 2 seconds. All those in favor of moving out of exec, say aye.
Aye.
Opposed? All right, we are done.
How many more, we don't have any more House bills?
We haven't been assigned.
You know,